Okay. All right, I think we're going to get started with the next session. Okay, I got the thumbs up. Well, good afternoon, everyone. Thank you for the opportunity to be here. My name is Dave Shearer, and I'm an orthopedic trauma surgeon here at UCSF. Are there any orthopedic surgeons here in the audience by any chance? All right, we got one. Okay. Hopefully, despite everyone's different backgrounds, some of what we're about to talk about today is going to resonate with you. I'm going to talk about our Department of Orthopedic Surgery's global outreach program, which is called the Institute for Global Orthopaedics and Traumatology, which we call IGOT for short. And I'm really excited to open this program. But before I go further, I wanted to introduce two of my very close friends and colleagues, Sam Morshed and Sanjeev Sabharwal. So I'm going to turn it over to them to just briefly introduce themselves and also just share a little bit about how they got involved in this work. So Sam?
Thanks, Dave. It's a real pleasure to be here with you all. As you guys can see there, I'm a class of 01, School of Medicine, so wonderful to be here with you. My journey really started when I was a medical student here. I was able to take a year off of med school between my second and third years and travel around the world. I spent some time in the Middle East. I spent some time in Latin America. Really helped solidify for me my desire to want to include global health as part of my career. I was an orthopedic surgery resident here. And we, at the time, were starting the first of its kind global orthopedic rotation. So UCSF was the first orthopedic surgery program in the country to provide a funded experience during the fourth year of residency to travel abroad. We had a relationship with a clinic in South Africa, and all of our residents had the opportunity to go there during their fourth year. Yet another opportunity to really explore what global surgery was like and begin to think about how to incorporate that into my career. I joined the faculty here after my fellowship in trauma in 2009, and was lucky enough to have brilliant residents like Dave, who continued to kind of push us to expand our programs and develop what I think was really a novel for its time, not volunteer-based partnership with a number of global partners where we really invested in sustainable research and education programs. And you're going to hear a little bit about those in a moment.
Thanks, Sam.
All right.
Sanjeev?
Thanks, Dave. So I'm Sanjeev Sabharwal. My journey was a little different. It was literally traveling east to west in installments. I grew up in India. I went to medical school there, and while in medical school, I realized that some of the learning was not very contextual. We were reading a lot of books that were authored by British and American authors. And what I was seeing in the clinics and the wards was very different. So it sort of made me a little uncomfortable. I was like, I want to go where the quote-unquote gold standard things are being practiced. So I didn't do any postgraduate training in India, but I did finish medical school there. And then I traveled west. I was in the East Coast for a while. I did my orthopedic residency actually in Vancouver, Canada, University of British Columbia. Then came south to California, did my pediatric orthopedics there, and then I had an interest in limb deformities. Went back east to Baltimore, where they had a special center for deformity correction, and spent 9 months there, and then just went up the turnpike in New Jersey and was at Rutgers for about 21 years doing pediatric orthopedics at Rutgers Medical School. And during that time, during my clinical years in the U.S., I did pretty regularly go back and forth to India, and we started this sort of combined Pediatric Orthopedic Society of India and Pediatric Orthopedic Society of North America exchange and combined meetings. So that sort of got me reintroduced to my birth country. And that was great to sort of develop relationships. And then during one of these meetings, I actually met Colleen Sabatini, who's a co-director with Dave at IGOT, and we were just talking, and he's like, she sort of, in a way, enticed me and said, well, if you're doing global work, you should come to California and work at UCSF. So that's what I did. After 21 years at Rutgers, I moved to UCSF in 2018, and it's been really very grateful. It's been very beautiful to work with people like Dave and Sam and others, and yeah, it's been a great experience. So thank you.
Well, thank you both. I want to share also a little bit of my journey to getting involved in this work. I think for each of us, it's a little bit different. For me, it really started where I grew up. I grew up in a small town called Toppenish, Washington. I don't know if anyone's spent any time in Eastern Washington, but it's a small, kind of economically disadvantaged town that's on a Native American Indian reservation. That's a majority Hispanic population. It was a community that was really rich in culture and resilience, but many families face the realities of poverty and limited access to resources. I'm not sharing that because it's my own sob story, but really because it taught me an important lesson. My opportunities in life were built in large part on privilege, a stable home, good health care, and strong educational support. Many of my friends in Toppenish, I believe, were as or more talented than me, but just didn't really have the opportunity. And this led me to feel that my future was working in a rural town, much like the one I grew up in, doing family practice medicine. But two pivotal things happened in medical school that changed that path. First, I was exposed to the immediate and powerful impact that an orthopedic surgeon can have, taking a patient who's suffered a devastating injury and in a single operation, restore their ability to walk, work, and live independently. Second, I had my first global health experience in Guatemala working in a pediatric clinic. The disparities I'd witnessed growing up in my hometown of Toppenish were very real, but in Guatemala, I began to grasp the depth of inequity that exists around the world, especially where healthcare resources are profoundly limited. When we think about global health, we often focus on infectious diseases or maternal care, but traumatic injury, broken bones, and mangled limbs are a silent crisis. Around the world, injuries kill more people every year than HIV, tuberculosis, and malaria combined. In low and middle income countries, many hospitals lack the equipment, implants, and training to save a limb after a severe injury. Too often, amputation becomes the only option, not because it's the best medical choice, but because the tools and skills for limb salvage simply aren't available. At IGOT, we work to change that, not with short-term fixes, but by building local expertise. One of our most impactful programs is the SMART course. It stands for Surgical Management and Reconstructive Training. It's a hands-on course that brings surgeons from across Africa and other low and middle income countries together to learn advanced limb salvage techniques. They take those skills home, train their colleagues, and eventually an entire region has access to improved care. The ripple effect is powerful, with hundreds impacted by each course and thousands over time. Today you'll see this impact in action. First, we'll share a video from a SMART course in Tanzania, the energy, the skill building, and the immediate difference that it makes for surgeons and their patients. Then we'll travel through video to Samburu County Referral Hospital in rural Kenya with my colleague, Dr. Daniel Shuto. There you'll see what these skills mean for real patients, the difference between life as an amputee and life with a salvaged limb. At IGOT, when we talk about capacity building, it's not a buzzword. It's the moment a patient walks out of the hospital on 2 feet instead of crutches. It's a breadwinner returning to work instead of facing a lifetime of dependency. It's dignity, independence, and hope. And it starts with the kind of training you're about to see. So we'll start now with the video about the course from Tanzania.
Every year, between 20 and 50 million people are permanently disabled from road traffic injuries, and over 6 million die. That's twice the number of deaths than HIV and AIDS, TB, and malaria combined. Many of these are preventable, but local surgeons in countries with limited resources lack the training required to perform life-saving procedures.
As we know from the census of 2023, The population of Tanzania is approximated to be 60 million. I remember when I started working here at Moi in 2007, most of the patients, they have open fractures.
The major cause of musculoskeletal injury here is motor traffic crash. With the availability of motorbike has increased the numbers.
Based on our current estimate, about 60% of the patients who have musculoskeletal injuries are the result of border driver or the motorcycle drivers. And most of the patients have open tibia fractures, and they're usually associated with soft tissue defect.
Now, we had a lot of problems managing patients with fracture and soft tissue loss. After spending so many years in hospital with infection, majority ended up with amputation. I have been working for some years, collaborating with IGOT. I think we started the first serious contact was 2010. We have been working together, conducting a training here in Tanzania, which is the same SMART course.
Full-blown collaboration came in 2012 when we have the first Moi trauma course, which is called the SMART course, whereby we had a series of lectures, cadaveric dissections, sawbone experiments in the lab.
Historically, the method for doing global orthopedic work has been to do surgical mission work. And that refers to a surgeon like myself from North America going abroad, finding a hospital and doing as many surgeries as I can. If I operate really hard for a week, maybe 15 or 20 surgeries in a week would be realistic. If instead I go and am able to train one surgeon locally, that surgeon, even more conservatively, let's say they do 10 surgeries in a week, that's going to be 500 surgeries in a year. Over the course of 10 years, that's 5,000 surgeries. And if you imagine that's a young surgeon who has a 30-year career, they've now done 15,000 surgeries. So instead of my 15 or 20, we're comparing that to 15,000 surgeries that a surgeon who's well-trained can now do from one of these educational courses. These educational courses, like the SMART course that we're doing, we are the global leader at doing global orthopedic education. They are directly addressing this need to create health equity. We're really at the heart, I think, of the mission of the Department of Orthopedic Surgery and UCSF more broadly.
IGOT's mission has taken it far beyond Tanzania. These needs stretch across the globe. For nearly 2 decades, IGOT has worked to eradicate the unnecessary loss of limb function by increasing the number of surgeons who can provide vital orthopedic care in the regions that need it the most. IGOT has hosted 35 SMART courses in 6 countries. Through these courses, we have trained over 3,000 surgeons across 55 countries. Join us in equipping surgeons worldwide with the skills and resources to end preventable disability. Your support of IGOT will help us save limbs, livelihoods, and lives.
Okay, so I just want to pick up and take some time to give Sam and Sanjeev, ask them a few questions just to share some more about their experience dealing with some of these complex injuries that we're trying to reduce disability from through the SMART course. So Sam, I was hoping you could start just sharing a little bit, your day-to-day is dealing with these complex limb injuries. And I wonder if you could just talk a little bit about what it's like for a patient going through one of these injuries from the time of injury and through that process here in the US, and then compare it to what that's like in some of these lower resource settings.
Sure, Dave. So I attend at San Francisco General Hospital and at UCSF, and my daily routine is taking care of patients with high energy lower extremity trauma. Patients here have a number of advantages, right? If you were unfortunate enough to get into a motor vehicle collision and have a bad injury like this, you would probably arrive at San Francisco General within an hour of your injury. You would receive world-class, not just orthopedic care, but general surgical care, all of the subspecialties that allow us to have a really premier level 1 trauma center here in the city, you'd be the beneficiary of all of that, right? Multidisciplinary care. We'd be able to take care of your limb-threatening injury expeditiously, and work you through a series of interventions that would really try to optimize the function of your limb. I spent a lot of my academic life actually trying to convince surgeons here that sometimes an amputation is not a failure of surgical care. That's just what is in the best interest of a patient. But we have the luxury of having all of this technology, access to world-class microvascular surgery, vascular surgery, orthopedic care, orthopedic implants, rehabilitation that's incredible, including orthotics and prosthetics, right? We will say now, I mean, you all have seen these videos of people in the Special Olympics that are running 100 meters, faster than I could ever run them on these incredible prosthetics, right? Those just aren't a reality in most of the rest of the world. In fact, even here, when you look at the cost of limb reconstruction or salvage versus amputation, over a lifetime, it's much more expensive to have an amputation mostly because of a lifetime of using really high-end prosthetics, which are very, very pricey. Let's now move to Tanzania. If you're in Dar es Salaam at a very busy trauma center, and I mean, it's hard to imagine the magnitude of and the volume that is seen at a lot of these busy trauma centers globally. I mean, the trauma center in Dar sees probably 5 times as many open tibia fractures a year as the busiest trauma centers in North America. And that's just one place. There are dozens of these incredible hospitals with incredibly dedicated people. Still, they really suffer from, and the patients really suffer from, first of all, no real functional EMS, right? So if you have a bad accident, you are dependent on either friends or family, or if you can flag them down a taxi that'll actually take you, or one of these bajajis that will take you to the trauma center. Most patients aren't presenting for days, right? We're talking about minutes here in terms of getting expeditious care. There could be days or even weeks until a lot of these patients find their way to one of these tertiary centers. And even then, you can imagine that if you had a limb-threatening injury, a vascular injury, the die is already cast. That limb is not going to be salvageable. Let's say it's just an open fracture, but you don't have neurovascular compromise or something that's immediately threatening. You've got an infection there by definition, and that's going to be another limb-threatening problem. That's going to take all kinds of resource to get you through several rounds of surgery to even begin to try to reconstruct a limb like this. Then you don't have the know-how. I mean, what we really focus on in these SMART courses is not just management of open fractures, but soft tissue reconstruction, right? Because if you can't get these wounds covered, these broken bones covered, those bones are never going to heal. They're going to get infected, and these patients are going to lose their limbs. And so the downstream effect of that is a much higher rate of limb loss. And you can see that if you're walking the streets in a lot of less developed, environments where, you've got the burden of amputees, who are really condemned to a life. They go from being breadwinners and economically contributing to their families to really being, resorting to having to not work and to beg for money and food, and it's a cascade that takes a lot of families that are on the edge and casts them into poverty. So those are really the kinds of those are some of the differences. We can talk more about them, but
can you elaborate a little bit on the importance of plastic surgeons in our lives in terms of some of these limb salvage and how the SMART course deals with that?
Yeah, absolutely. So plastic surgeons are absolutely vital. So we work hand in hand with our plastic surgeons here at UCSF and San Francisco General Hospital and taking care of patients with these problems, as well as patients who come in with problem fractures, infections, and bones that don't heal. Yeah, I mean, we're lucky enough here to have a wonderful partnership with the Department of Plastic Surgery, and we've taken that partnership and taken it on the road. So we travel with a group of plastic surgeons. Mike Terry kind of heads that charge. He has a joint appointment in our department, and we're going to be traveling to Tanzania in just a couple of weeks for another SMART course. So it's absolutely vital. They do a lot of the teaching. There are a lot of orthopedic surgeons that are also facile in these techniques. And we're not talking about microsurgery. We're not taking these giant, $150,000 Leica microscopes to Africa. I mean, the techniques that we teach in terms of soft tissue rearrangement don't require microsurgery. They're mostly rotational soft tissue transfers and things that we can teach most surgeons to do effectively, and we've actually published on our rates of teaching these techniques and surgeons who train in them being able to implement them effectively in their own setting.
Yeah, unfortunately, in most of the places where we're doing the SMART course, plastic surgeons really aren't available to deal with a lot of the problems that involve both the bone and the soft tissue. And so a big part of the SMART course is empowering the local orthopedic surgeons to not only be an orthopedic surgeon and treat the bone, but also be a plastic surgeon and be able to treat the soft tissue. And it's really critical to the success of a lot of these procedures. Sanjeev, can you just share a little bit about that kind of IGOT's approach to education and different models for education, maybe how it differs from historical ways of doing this work?
Sure, Dave. I mean, like you said earlier, we are all about, capacity building. We're not doing parachute surgery, and there's nothing wrong, as you said in your video, about, the mission surgery that has been popularized and is over-dramatized. It gets the adrenaline going. So it's really not about the adrenaline. It's about really getting to the core of it. And I think like SMART course is one, and then there's other educational things that UCSF and other partners, across the globe are doing. And my mom was, when I was growing up in India, this was her, pretty classic line. She'd say, they can take anything away from you, but they cannot take away your knowledge. And I mean, that's a cliche in a way, but that's so true. And I think a lot of teaching and training is embedded in that principle that you teach someone, principle-based techniques. And when we go to SMART courses and things, there's a lot of unwritten curriculum. Like Dave and Sam mentioned about orthoplastics kind of combo. And I remember we did this course in Nigeria, and the dynamics between orthopedic surgeons and plastic surgeons, they were on two separate, literally and figuratively, two separate ends of the room. And then by the end of the course, they were sort of, collaborating. So I think just to see, different specialties interact with each other in a collegial fashion also helps with capacity building. And, we've taken it to another level at UCSF where, Rick Coughlin, who started IGOT way back, started this, and I think UCSF was the first orthopedic department to start overseas rotation for residents. And that's been going on. And now, under Dave's leadership, we've got trainees, mostly postgraduate trainees, who come from Tanzania, Ghana, and some other places to come and visit UCSF. So it's truly like a bidirectional exchange so that, our trainees understand what's happening there and vice versa. And besides, again, exchanging knowledge and skills, I feel the attitudes, the cultural humility that, of course, our trainees get, I think stays with them, even if they're not doing global work. So I think that's another model. And then, of course, we do some webinars, which, thankfully, post-COVID, that's become a thing no matter where you are. And I think a lot of surgeons, both sides of the globe, can't quite travel all the time with the expense and the time, et cetera. And so I think webinars is a great way to sort of facilitate that, or even complement, like do a webinar and then go ahead and teach something similar, in a place you're visiting. And then finally, I feel something that is probably not focused as much, we talk a lot about the north-south relationship, if you will, a high-income country and a low-middle-income country. And, of course, the initial thing was the whole medical colonialism thing, that it's a top-down approach. Now that's changing, and of course, we understand how we can all learn from each other, including frugal innovations, how value-based care is a big thing, right? And, value-based care in limited resources is an actual thing. And, people don't seem to get around it and say, this whole thing about doing more with less is actually practiced all the time there, so why not adapt and adopt some of that? And then finally, I feel just nurturing a South-South relationship, and the high-income country can sort of facilitate that. And a great example is like in the Tanzania course that Sam mentioned, we are having a surgeon from Nigeria come to Tanzania to sort of talk about it. And similarly, I think Kenya, Dan Shuto, who Dave mentioned, you're going to see his video, sent me a picture the other day where an orthopedic surgeon from India was visiting Kenya. So they've sort of, understood a little bit of the reality on the ground. They've had similar experiences. So I feel that's another part of education and training that just needs to be explored and expanded more, is to just nurture this South-South relationship, if you will.
Thank you both. Now that we've talked a bit about the SMART course, we're going to go to the next video, which is really aimed to, is a video from Daniel Shuta, who was mentioned, a surgeon in rural Kenya, and really to get an idea of how these two pathways of amputation and limb salvage impact a patient in a lower resource setting.
Located in the North Rift Valley region of Kenya, Samburu County is a semi-arid hardship area where 80% of the population are rural dwellers and traditional livelihoods passed on across generations. Many of the households struggle to meet basic needs for food, water, and healthcare, and the ability to walk is crucial for the daily activities. Located in Maralal, the Samburu County Referral Hospital is the only hospital with one orthopedic trauma surgeon serving a catchment area of more than 500,000 people.
I fell from a tree while I was feeding my cows. I took one day to reach to South Maralal Hospital for treatment. I was told the limb cannot be salvaged, and the only option remaining was to do an amputation. It was challenging. It was not acceptable at first. After extensive consultation, we agreed to amputation. I used to be a herder. Now I am a student. My normal walking routine has been interfered. I now use a prosthesis, though worn out, torn, it's getting smaller. It needs repair. We need a new one. It is very costly.
I was taking my grandchildren to the hospital. After being admitted, I was sent to go and look for money. I was coming home, and that is when we got in an accident while we were on our vehicle. I got fractures of the leg, whereby I was given the sad news that my leg will not be salvaged. It was devastating news. I was a primary school teacher. I had a maize plantation. I had cows and goats to milk. I have family to move around. I have friends to move around and see. All that I know now is not possible. All our family resources were used on seeking healthcare. We sold our piece of land, we sold our animals. The cheapest prosthesis I was offered in the market was 130,000. I couldn't afford it. So we opted to come home with a walking frame, and this is how I was mobilizing at home.
Over the past 5 years, Dr. Shutro and his team treated more than 30 patients with reconstructive surgery. Patients that were to undergo amputation are now walking again, farming, returning to their roles in the community.
I was driving a motorcycle when a car stepped on me. I managed to have fracture of the tibia fibula. That's when I was first put on a nail. I was seeing that my leg was not going to get well. The doctor told me that they'll do a flap, and the doctor told me that if the flap fails, I was going to be amputated. The wife and the children just worried about them because I'm not be able to provide for them. The flap also did well. It healed. Everything was well, and I'm fine now. I can walk around. I can go see my friends, see livestock. Everything is now okay. I can go to long distance and go and do my business, the trade. I can look after my farm.
Some robbers attacked me and they injured me badly, very bad. The fracture is bad, some infection. This is what happened to me. My leg was cut completely. I'm so stressed because I'm thinking that I will lose my leg forever. In my career, I'm a driver. So that's a big worry for me because I am using my leg to drive. When you lose your leg, it is completely like you are dead. The first treatment I received, it helps me so much. From there, we continue reconstructing the leg. Now, my life is good. I'm really happy now. I am back to stay with my people, and I am walking again. I am driving again. The life now is normal. It's like my past story. There is a hope. There is a hope. You can have to walk again when you trust this process.
Okay, so I just wanted to take some time to talk a little bit more about how these amputations impact patients, and I think you already alluded to a little bit some of our visions of what it's like to be an amputee here in the United States, and I wonder if you could just elaborate on those perceptions and then what it really looks like in most settings around the world where some of the resources may not be available.
Yeah, I mean, I think you heard in the video how expensive even the most rudimentary prosthetics are. I mean, it bankrupts families, and there is a tremendous amount of stigma associated with it, as you could see. It's I don't like the term saving a leg or a limb. I think there's judgment implied in that, but there is an urgency, I think, in environments like Samburu County in trying, because the consequences of limb loss are so much more dire, right? And that's what we're really trying to do, is equip people, surgeons, with the know-how to undertake those kinds of operations when they are possible. And the techniques we teach are, I think, they're time intensive. And you saw some of the devices that are used. I mean, some of those reconstructions, the flaps and the use of these ring fixators can involve many months, sometimes even years, to get to an endpoint. But they are cheap, they're locally available, they're reusable, and I think with the right training, I think we've shown that these techniques can be implemented successfully. So yeah, I mean, I think we try harder, I think, because the consequences are so much more dire if those patients are losing their limbs.
Thanks, Sam. Sanjeev, there was one of the first amputee was a child. We saw a lot of children and families in the video. I just wanted to get your perspective as a pediatric orthopedic surgeon. Sam and I are adult orthopedic trauma surgeons, but from your perspective, how do these injuries or other limb problems affect children differently than adults?
Yeah, no, that's good. Again, the classic, thing is children are not small adults, right? So, and anytime a child, especially a young child, gets injured or is affected, impacted in one way or another with a limb problem, it's not just that child, but it's a caretaker as well. So, it's 1 + 1, if not 1 + 2, that's impacted. And obviously, a child has so many more years or decades of anticipated healthy living. And, people throw around this term of DALYs or disability-adjusted life years. And so if you do the math, if it's a young child who gets injured, it impacts their livelihood, the family's livelihood, for so much longer. So I think that's one part. The flip side is that unlike adults, kids are very resilient, both physically and physiologically, and they heal. And while in an adult, you need the bone to be, let's say, perfectly straight, in a kid, you can accept a fair amount of angulation, even, here in North America, because nature takes care of it, and there is a lot of bone remodeling. So I think there's things that sometimes work to your advantage, and sometimes they don't. The other thing with pediatric issues related to limb is that it's not just trauma, right? A lot of it is congenital. Congenital deficiencies or differences are quite common, both here and I guess all over the globe. But the management is quite different. And just like we heard about amputation versus reconstruction, or like Sam likes to say, limb optimization, the social and the psychosocial barriers, the resource availability, the stigma, et cetera, is a little different depending on where you're born and raised. So I think just like, so amputation takes even a harder hit for certain severe congenital problems. Having said that, going back to this whole South-South relationship, I think locally made prostheses, or, again, I'm bringing India back into the picture, but there's this prosthesis called the Jaipur foot, which was, meant in rugged environments, tropical environments, very, not very expensive, like 1/50th of the cost of what a fancy high-income country prosthesis would cost. So I think transferring that kind of technology to another part with limited resources is great. And then, of course, we've got things like post-septic deformities, developmental problems. Somehow, in the African continent, a lot of kids have this thing called Blount's disease, which is, severe bowing of the leg. We see a little bit of it here as well, but it's a lot of that. So I think, again, going back to teaching, training, sharing knowledge is very relevant. And I think that's what courses like Smart Course, webinars, et cetera, do. And I think we learn from each other. So I don't know, it's a long-winded answer.
Dave, if I can just, I don't know if you caught the part in the video where that young man was talking about how he used to be a herder. He used to have animals, right? And what happened after he lost his leg? He had to go to school, right? It's a big,
which is interesting because we think, oh,
right?
That's actually a good thing, maybe, right? But in their culture, that's sort of like you've sort of been ostracized. You're like weak, and you're now going to school. So it's very interesting because it's a pastoralist culture where the ability to walk and do these things is very critical to your social function and ability to support your family. So it's I found that very interesting too, but it's sort of flipped from the way we might think about it. Before opening up to questions, I wanted to ask one more question just about how do you guys see, we've done courses in 6 countries, but a lot of surgeons can attend and they do go back to where they come from. But how can we, expand the training? What do you envision? I think you've alluded to some things, but how can we reach more surgeons and more patients ultimately around the world?
Well, one of the reasons we started doing the SMART course, we took the show on the road, was it just was cost prohibitive to bring surgeons from around the world to the States to learn. As Dave mentioned, we have created a reciprocal program. This was a long time goal of ours to actually fundraise so that we weren't just sending our residents overseas, but that we could actually we could reciprocate that in that relationship and actually have trainees at the institutions that we partner with come here. So I think that's part of it. I think leveraging technology, Sanjeev, have run these incredible webinars that I think have a tremendous reach. We're going to continue to do the SMART courses because, just taking a couple of surgeons to, say, Africa, I mean, we'll have probably most of the orthopedic surgeons in East and Central Africa in Dar es Salaam in 3 weeks. That course sells out immediately. There's 150 surgeons there, which is, if you think about, one surgeon for every 500,000 people, that's pretty much everybody is gonna show up to these courses. So they're very well subscribed. There's a huge amount of demand for them. I think it's gonna be kind of a multi-pronged approach, but it's hard. It's hard to fundraise for this kind of work and raise awareness, about the problems that we're treating and are helping these surgeons that we partner with treat.
Yeah, no, I agree. And again, it's not one size fits all, like Sam said. I feel the hybrid approach is great. And again, there was a silver lining to COVID in terms of, getting the remote learning a little bit more fine-tuned. I also feel, embedded in this are 2 other things, which, again, to make something successful like the SMART course and relationships, it's you gotta have, I think, 2 key ingredients. One is established trust, on both sides, and you gotta live up to that. And then the second is it has to be locally relevant, right? You can't be teaching something that's not relevant to them. And sometimes it takes a few visits and a lot of conversations to figure out, what's actually relevant there and what's the need. So there's no point in teaching something that's very, upscale or downscale. You need to know your audience, basically. And then finally, again, Sam and Dave and others have done a great job with this. Research is not just writing papers. It's putting it out there, what is it that people want to know? And I think sometimes building infrastructure, doing collaborative research is very important. And now, interestingly, with AI, one of the biggest hits with getting peer-reviewed publications for low middle-income country authors, besides not having the time and the resources, was, the English, the grammar. Things would just get thrown away. This is not a great paper when there was content in there. So I think now that's sort of the other part between that and having open access and, AI for its good and bad things. I think it's all going to help, and it's all going to complement each other. So it's not you got to do just the course or just a webinar. And I think adult learners are very smart, and they'll figure out what to do. And I think, some other places, and that's a very common surgical thing, to have these surgical videos, short YouTube or these other vendors, and people love that. So I think that's sort of the other thing. And just to push another part of UCSF, there's this thing called Global Help, and IGOT has a platform for education. And I think it's a pipe dream to say we got to build a core curriculum for someone who's practicing in Africa, let's say. But at least we got to start somewhere, get those authors in, and in some ways, and not to say one is better than the other, but what we are teaching our trainees is sometimes very relevant to practicing surgeons in other parts of the world. So if you've got that resource for our trainees, how hard it is to just make it open source and let others benefit from that. So I think there's many creative ways to learning.
Great. Well, I wanted to give the audience an opportunity to ask any questions, if there are questions about IGOT or this type of educational work that we're speaking about. There's a question in the front.
Well, ophthalmology's been doing what you've been doing since the 1960s. The problem that we ran into is equipment. Now, you can train somebody all you want. If they can't get equipment, it's almost worthless. So what are you doing about the equipment? Now, ophthalmology is more dependent on equipment than you guys. However, you still need clean surgeries. You still need the right screws, hammers, and everything. So what are you doing about that?
Yeah, it's a really great question, and I think it's very true. First of all, a lot of the things we're talking about in terms of soft tissue coverage and which is a big part of what leads to infection and amputation and the things we're trying to prevent, is very you need a scalpel. It says there's not a lot of equipment involved in doing a soft tissue flap, so that's part of it. The orthopedic part is the harder part. And for that, we partner with there's a nonprofit that we work with a lot that's probably our main partner for resource issues. They manufacture orthopedic nails and also repurpose external fixators, which are a big part of a lot of these complex limb reconstructions. So while we don't provide implants, we have partners that we work really closely with that do. And the other thing that's happening certainly since the 1960s is that a lot of, Sanjeev alluded to sort of South-South partnership, but a lot of the manufacturing of implants now is not coming from US manufacturers, it's coming from India, it's coming from China. You can get this very similar implants now for less than, a tenth of the cost of what it would be for the United States. And so that's really expanding access to be able to do a lot of these procedures. And then the training piece becomes, a bigger part of the equation. But yeah, it's a great point and definitely a limitation. Go over there.
Yes, two questions, one short. Is IGOT able to be done kind of cross-disciplinary, or is it strictly for surgery?
Yeah, that's a great question. Our focus has definitely been on the sort of limb injury, and orthopedics has been the focal point. We have done a lot of partnership with plastic surgery because there's so much cross-disciplinary work that happens there. But we're very much open to collaboration across other specialties, but historically that has been the major focus. Yeah.
Great. The other question is the ability to train kind of technicians. I believe the UK did some work in Rwanda with surgeons, and they ended up training orthopedic technicians. And so I think they only had 5 orthopedic surgeons for the country at one point. So is there any movement to help develop and democratize as well as expand the workforce that's perhaps different from what we have, but it may work in other countries?
Yeah, it's a great question. It's sometimes called task shifting, the idea of training sort of non-physicians in some of the techniques. And yeah, that's more prominent in some countries than others in Africa. But they also participate in the SMART course. They're called clinical officers. So we've certainly welcomed clinical officers to participate. Most of them aren't doing the more complex limb reconstruction. They're doing more the initial first line care of open fracture debridements and things like that. But you're absolutely right. I will say that the residency training programs really have, I would say, almost exploded over the last probably 5 to 10 years. So the number of residents being trained has gone up exponentially. And so there are now a lot more physicians, but a lot of them almost happen too fast to the point where the quality of the training isn't as maybe in some ways as good as it could be. And so I think also is part of the importance of, I think, some of these ongoing partnerships and stuff. I don't know if you guys have other comments.
Yeah, I mean, just to the same point, in pediatric orthopedics, there are simpler, quote unquote, simpler things that actually can be task shifted. Like clubfoot is a great example. And it's interesting how, clubfoot went a whole 360. It started off being, a lot of manipulation, forceful, and then that didn't give good results. And then it went to a full circumferential release. And then this thing called Ponseti treatment took off about 30, 40 years ago. And that was a game changer, not just in the US, but globally, because it all involves like very strategic stretching casts and then just a little tenotomy of the Achilles, which is honestly done a lot of places, including Haiti and in parts of Africa, not by physicians, but by other sort of paramedical people. And then, but part of the Ponseti treatment is not just the tenotomy and the casting, but then bracing. So bracing was a big expense till a lot of people discovered that you can have the local cobbler make these braces, and that's what's been happening. So, there's some NGOs, et cetera, that have got the local cobblers to manufacture these real low-cost braces, and there are now peer-reviewed papers saying that the impact is and the outcome is as good as with high-resourced environments. So I think that's a great example.
Yeah, I think there's a question over here.
Thank you for the interesting talk. Can you speak to the sustainability of your program after you're in a community teaching and training, and then you leave? How do you ensure sustainability over time?
Yeah, I mean, I think that's a big part of the beauty of an educational intervention like this is that whatever education's imparted we're not training, surgeons from here to go stay there. We're training local surgeons who are already there, who are already in their communities. So I think that whatever education is imparted naturally sustains itself. We've also, luckily been able to sustain these partnerships and courses over time. So we've been able to, continue to keep going back and maintain relationships. And we've done a number of studies just looking at, trying to understand what the follow-up 1 year later, how many people are continuing to do things, and try to measure impact that way as well. And it really does seem to, they're pretty, we're not trying to cover all of orthopedic residency in one of these courses. We're really trying to focus on a few low resource, but very high impact procedures that can be done. And so I think that's part of what makes it a little more sustainable than trying to start a residency program or something like that out of nowhere. But do you have any comments to add to that?
I think we're out of time.
Okay. I think there are more questions. I apologize. I think we're getting yanked off the stage. But I really want to thank everyone for being here and listening to a little bit about the work we're doing in orthopedic surgery. I hope this, as a UCSF community, is something that we can be proud of, extending our mission to places that where it's needed the most. I really want to thank my colleagues, Sam and Sanjeev, for their expertise and for partnership, and also everyone in the audience for the time and support. So please don't hesitate to reach out to us if you're interested in learning more or getting involved in this type of work. Would definitely appreciate any engagement with all of you. So thank you again.